Right, good morning. I am Jay Patel. I'm one of the third-year traditional cardiothoracic surgery fellows here at VCU. And today with me, I have Dr. Zubair Hashmi, who's one of the cardiac surgeons here at VCU as well. So thank you for being with us today. Today, we're going to be talking about post-infarct VSDs for our 5-minute consult. So Dr. Hashmi, you're called to see a 60-year-old male with a past medical history of coronary artery disease who presented with an MI in the LAD territory that was successfully stented. But 5 days later, he presents with worsening dyspnea, hypotension, and a harsh holosystolic murmur that was heard at the sternal border. How would you evaluate and work up this patient?
So 4 or 5 days after treating that LAD territory, having a holosystolic murmur, I'm concerned about a post-infarct VSD. So my first line of testing would be an echocardiogram to rule this in or out.
Okay, so say you get the echo and it shows a 2 centimeter anterior located VSD with a left to right shunt. What would be your next step in terms of the workup of this patient?
Yeah, so once I have it confirmed that it is a VSD, I would get a right heart cath as well. With the right heart cath, just making sure what my filling numbers are, my wedge pressure, my atrial pressure numbers, looking for my QPQS and any oxygen content step up. I believe somewhere around 9 to 10% step up from RA to PA will be indicative of the post-infarct VSD.
Okay, so more than 9% and then a QPQS of more than 2.
Correct.
Okay. So say this is confirmed on your right heart cath and your echo. So how would you manage this patient next? And to whom would you offer an operation?
So, risk stratifying them, but on top of that, medical management to start off with, making sure we have good inotropy, decreasing our SVR, forward flow, watching our end organ perfusion, lactates, mixed venous, and going from there.
So say you're medically managing this patient and over the next 24, 48 hours, he's starting to declare himself as impending cardiogenic shock. So at which point do you make the decision to escalate to mechanical circulatory support, such as a balloon pump or VA ECMO?
Yeah, I think the tendency for these are to initially go with the balloon pump, decreasing your afterload, making sure you have forward flow so that not a lot of blood flow is going through the shunt, through the VSD. But ultimate goal is your end organ perfusion. If there's any signs of end organ perfusion being of an issue, I would skip the balloon pump or convert the balloon pump to VA ECMO. Being able to decompress, both sides of the heart, allowing our scar tissue to form, giving the heart time to rest and heal, and making sure that our body is well perfused.
Okay.
So just VA ECMO.
So say you cannulated this patient for VA ECMO, when do you make the decision to take him to the operating room?
Yeah, I think that's a good question. Even from my training days to even now, there's discussions of when is the right time, right? An infarcted muscle is not going to hold your sutures. So you want to give it enough time to have the muscles scar down so you have good healthy tissue to place your sutures. I think that more consensus now has been, 7 to 10 days is probably a good time. You have good protection with ECMO, or if you're on a balloon pump or what support. So the body is well supported, so there's no urgency to rush into these operations. You want to have a good, safe operation and get them off the table to a good recovery. So I'd say a good week to 10 days.
Okay. So say that amount of time has passed and now you are planning a repair of this patient's VSD, who also will need a bypass operation as well, given his critical coronary artery disease. What would your surgical management would be, such as your cannulation strategy, your cardioprotection, and how exactly would you repair this VSD?
Yeah, so cardioprotection is of utmost importance. Bicaval cannulation, central aortic, antegrade, retrograde. So for the anterior VSDs, for the most part, we're not bypassing the LAD territory, but if they do have any other multi-vessel disease, I would do those first if it's an RCA lesion or something like that. The only time that, you know, we do go after an LAD territory if it is like an apical VSD, and then your disease is, let's say, proximal to the first septal perforator or in that region, then you could, you know, safely do a bypass to the LAD and still then exclude your apical VSD. This patient has an anterior VSD, so for the most part, I'm probably leaving the LAD territory alone. And like you said, this person was already stented before. So if there is any other multivessel disease, address that, and then definitely give some cardioplasia down those grafts. Cardioprotection is of importance on these VSDs because you have a lot of raw, dead tissue or necrotic or ischemic tissue in there that you want to make sure you protect the heart well.
Excellent. So then how would you patch close the VSD, and then how would you address closing the ventriculotomy that you've created?
Yeah. So making our ventriculotomy on the LV side a few millimeters lateral to the LAD territory, extending that, identifying your VSD, patch closing that primarily, taking your bites wide through the RV, through the septum, through the patch, being able to isolate the VSD out, and then sewing that to the healthy tissue. After that, once that is done, closing the ventriculotomy in 2 layers with a whole separate suturing. You want to be able to have good closure but no tension, using either felt patch, imbricating this, or core matrix, or some kind of additional support to help secure your closure in 2 layers.
As a last point, to which patients would you offer like a percutaneous VSD closure, or who would be a candidate for that over a surgical repair?
Yeah, I think getting your interventional colleagues, interventional cardiology colleagues involved early enough is good, because they will help determine if percutaneous is even an option, right? You need to make sure the location, size, the landing zone of the percutaneous device. So having a multidisciplinary approach from the get-go is probably great to help determine which pathway to take, but I would get them involved from the beginning, even if you're not going down the perc approach, but having them involved.
Okay. All right. Thank you so much for that, Dr. Hashmi.
Yeah.
That was a great refresher on VSDs.
All right. No